Hello, good morning, and good afternoon. My name is Srinivas Murthy. I'm from the University of British Columbia in Vancouver, Canada. I was asked to speak about other therapies for COVID-19 and some new and emerging ideas. My disclosures is that I received funding from the Innovative Medicines Canada and as the Innovative Medicines Canada Chair in Pandemic Preparedness Research. I was given the non-enviable task of filling in the other department after the speakers that you have just seen, incorporating a variety of different therapeutic and biologic pathways as to how we can better treat critically unwell patients with COVID-19. And so it becomes a bit of a challenge to find out what should fit in that other box. But we found a few things. We'll aim to think slightly outside of the box, but incorporate things that are at least at the clinical trial phase at this point, acknowledging that there are a number of clinical trials underway for a variety of interventions. I'll direct viewers to the CITEL COVID trial tracker, which in real time updates which trials and where they are being performed and on what agents. Easily searchable and easily documentable. I use this to incorporate all of the trial registries that exist to see if there's anything from the other therapies box that needed to be addressed. A few things I will discuss are sort of less clinically relevant than others, but will give you an idea as to the diversity of thoughts out there. I also will reference this article. This is the JAMA review on COVID-19 that was published a couple of months ago, walking through some of the physiology of SARS-CoV-2 viral infections as it infects humans. We'll also sort of break things down into therapies that are targeted at the host and therapies that are targeted at the virus, acknowledging that some therapies work at that viral host interface. The first one is somewhat tongue-in-cheek, is low-dose radiation therapy. And so the radiation oncology community has hypothesized that maybe radiation therapy as it relates to treating patients with COVID-19 might provide benefit. And so there are currently, according to various trackers, upwards of 500 patients aiming to be randomized into clinical trials of radiation therapy as a potential treatment for COVID-19. From a biologic perspective, this idea has been floating around for 100 years, namely that the chest X-ray itself is therapeutic as it relates to treating a viral pneumonia. Obviously, no therapies have been proven to be effective in this regard, but the idea that directed and focused ultra low dose lung radiation for confirmed COVID-19 is being evaluated. I have not seen any effectiveness or efficacy data as of yet, but the trials are underway. Other things, cell therapies. And cell therapies are a bit more advanced in their trial base compared to the last topic. There are upwards of 5,000 patients in clinical trials, at least reported or at least planned. The challenge with all of these numbers is that many trials plan sample sizes, but fail to recruit them, and that's part of the larger challenge of COVID-19 research. One of the interventions is mesenchymal stem cells, which are multipotent adult stem cells that are present in most human tissues and can differentiate into multiple tissue types. These lack the ACE2 receptor and so don't themselves have a risk of becoming infected by the virus. There's been long-standing work, as many people in this audience know, for ARDS, and small-scale clinical trials have been done and are underway for general ARDS pre-pandemic. And they have a host of immunomodulatory activities as it relates to treating inflammatory diseases. Simultaneously, other trials are being done with derived natural killer cells that are derived from placental CD34 positive cells and then expanded and then infused into consenting patients. Both of these strategies, looking at cell-based therapies, have some biologic plausibility to them, and we await further data. When one can sort of envision the MSC approach as relates to how that would work as a variety of different pathways as to where benefit is envisioned, both at the secretion of cytokine perspective, IL-6 and so on, as well as decreasing apoptosis and increasing phagocytosis at the level of the macrophage. And so there are a variety of different strategies that MSCs might work. Next topic is nanobodies. Obviously, this audience has heard a great deal about antibodies and the monoclonal antibodies that are currently being scaled up. Nanobodies, which are single domain antibodies that have been shown to be produced by camelids, namely llamas, camels, which are these molecules that can be aerosolized or administered to patients directly. A variety of different groups have obtained or isolated nanobodies directed at the S protein as it intersects with the ACE2 receptor, specifically at the RBD component, where intersection across the virus host interface happens. And nanobodies have been engineered to target that, and in vitro have been shown to block virus ACE2 interactions. These have not reached clinical trials yet, but are in planning phase at this point. Obviously, given the production capabilities of these as it relates to the monoclonals, larger molecule, these nanobodies can be, in theory, mass produced, but obviously clinical effectiveness and safety remains to be seen. How it works is llama immunization happens. The nanobodies, the VHS molecules, are isolated and characterized and determine if they have cross-reactivity. If so, then they are subsequently scaled up and tested. A topic to keep an eye on. Anti-androgens are also of interest to a variety of investigators. This is ISARIC data from last month about the preponderance of male to female deaths as it relates to COVID-19. And so one of the plausible hypotheses here is that there is some biologic pathway that males will have that makes them more susceptible to death compared to females. Obviously, there are a variety of other factors that could contribute to this difference. And so a variety of investigators have thought about different ways. Remember, back in that pathway, the SARS-CoV-2 virion interacts with the ACE2 receptor after activation by the transmembrane protease serine-2 molecule. That molecule is activated by an androgen responsive element, making it a possible target for intervention and possibly a pathway why the male-female difference occurs. And there's a variety of different pre-existing literature that suggests both the androgen responsiveness and possible manipulation to modify disease pathway. There are a variety of anti-androgens that have been tested in prostate cancer and other therapies that have been postulated to be effective in COVID-19, which has led to some both good science and less good science, you could argue. This is a preliminary observation from the Journal of Cosmetic Dermatology, which reports male pattern hair loss among hospitalized COVID-19 patients in Spain, documenting a majority of them, of the males in their small sample hospital, have male pattern hair loss. Obviously, this does not prove anything one way or the other. But that being said, there are a variety of anti-androgens being tested in clinical trials across a variety of different populations, particularly in the critically ill, to examine benefit or risk or harm. Antidepressants, fluvoxamine specifically, has been shown to modify inflammatory pathways as relates to inflammation and sepsis previously in knockout mice who lack a pathway that fluvoxamine has. They have more likely death. Surfactants also are being evaluated in a variety of ways. Remember, surfactants are produced by type 2 pneumocytes, which are directly affected by SARS-CoV-2 infection. Obviously, this has been thought about quite a bit in terms of ARDS and the meta-analyses for benefit of surfactant administration in ARDS show no benefit. However, these trials are all reasonably small, A, and B, there is possibly an added biological plausibility of SARS-CoV-2 in surfactant administration. The challenge with surfactant administration is dose, duration, and delivery, and as well timing as to when to deliver it. Remember, in the neonatal population, it's administered via endotracheal tube and direct installation of liquid. There are ways of delivering it bronchoscopically, and as well a new aerosolized device is being developed and scaled out and investigated across a number of different places to see if it gets delivery of drug to distal alveoli. But the dose and duration remain to be seen, and obviously then clinical evaluations need to. So to conclude, obviously the biologic underpinnings of COVID-19 remain unclear, but into that vacuum, a variety of possible treatments have emerged. Fundamentally, to get answers, we need to coordinate these efforts. Having small scale studies that are hypothesis generating is great, but to formally answer whether something is effective or not, we need to coordinate all of our efforts to learn quicker. Thank you.